Hi, good morning, everyone. We are live on 137th CMAAO International Weekly Meeting. We are meeting every Saturday to discuss on a common topic, which is we are facing a regular problem, we are facing doubts, and today we have a very, very important topic. It's on sudden cardiac death. We've all seen recently a lot of early deaths, a lot of teenager deaths, which are happening, a lot of deaths which are happening while doing functional trainings and all that stuff. So today we have a very eminent speaker, Padmashri Dr. Mohsin Wali. We have to introduce him, we have Padmashri Dr. Wali is highly accomplished and well-sought physician. He served as a full-time physician for President of India, Mr. Venkataraman, Mr. Shankar Dayal Sharma. Beside, he was also been appointed to serve as a family of President Dr. Zakir Hussain. He was born in 1953 in Uttar Pradesh in India and was selected by UPMC both as a specialist and a consultant for a medicine in Post-Grad Institute of Medical Research and Education, attached to Dr. Ram Manohar Lohia Hospital in New Delhi. He's the only clinician in India formally trained. He is also been instrumental in launching the medicine in India, geriatric medicine in India through Faculty of Geriatric Medicine and Arbor University of Michigan, USA. He's the only trained doctor in water treatment and dialysis at Germany at thought of unitary efforts of quality of dialysis in India to improve the remarkable standards. He has contributed his achievements by the sizable number of books, chapters, and journals. I would like to invite him for a very important topic. Over to you, Dr. Wali.
Thank you, Saurabh, for your kind words. I congratulate you for continuing the legacy of our friend, our mentor, and a God-gifted human being, Dr. K.K. Agarwal, and our salutations to him. And congratulations for bringing ahead his mission through Heart Care Foundation of India and CMAAO's 137th event today as we have. And I would respectfully say my good wishes and my salutations and good morning to you and your all present, like Dr. Wasit Qazi, Dr. Chongwoi, and Dr. Hussain, Dr. Monica joining from US. And sudden cardiac deaths, as you have rightly said, is wonderful thing to know and to follow in the rest of our career because it's troubling us. A little heart on the drug level means the price could cause cardiac arrest. This is just a cartoon. But cardiac arrest is happening more frequently than we have seen in the past. And the reasons could be any. The reasons could be more awareness, or post-COVID scenario could be any. And just as we know, sudden cardiac death, because we see that cardiac rhythm irregularities, they become very prominent during this. And I hope I'm audible beyond the voice of the presentation. So the rhythm of the heart becomes erratic, the beating of the heart becomes erratic, and muscle contractions of the heart become erratic, which we know arrhythmias develop, and we know many arrhythmias which can be precursor to sudden cardiac death. As we all know, this is not synonymous with acute heart attack. So we have to just differentiate in terms of time. Sudden cardiac death does not give us time, while acute heart attack gives us time, and we can manage the patient, revascularize the patient. So it happens without warning, without the person's feeling any signs that something is about to happen, but it just happens. So when it just happens, it's a test of our skills, the test of skills present around. So sudden cardiac death is an unexpected death due to cardiac causes that occurs in a short time period, generally within 1 hour of the symptom onsets. Normally, we say it gives us roughly 10 minutes or less in a person who is known or unknown having cardiac disease. Then patient at risk for sudden cardiac death may have prodromes of chest pain, which they ignore, fatigue, palpitations, and other non-specific complaints. 2/3 of the cardiac arrests occur and they are clinically manifested as a first clinically manifested event in the clinical setting of a known disease in the absence of strong risk factors. And 25% of the victims have high risk markers, arrhythmogenic or hemodynamic, which can be both, and general patterns of heightened risk during the morning hours on Mondays and during the winter months, as we see all over the world now, they have been described. So if you see the chronology, as I have said, it could be chest pain, palpitations, dyspnea, fatigability leading to arrhythmia, hypotension, chest pain, again dyspnea and lightheadedness, loss of effective circulation of the blood and loss of consciousness. There could be biological death after the cardiac arrest, or we can resuscitate and manage. So it's not a random event. Most victims do have pre-existing heart disease or other health problems. And I have a family in which 4 people have got obstructive cardiomyopathy, and one young boy came to me 3 days back and he had arrhythmia and sinus pauses. So as many as 75% of the people who die of sudden cardiac arrest show signs of a previous heart attack or cardiac event. 80% have signs of coronary artery disease. So approximately 92% of those who experience sudden cardiac arrest because of lack of medical facilities available don't survive, unfortunately. So we have to work hard in this direction. And it kills more than 1,000 people a day or more, or 1 person every 90 seconds. We have lost many prominent people in India and outside India. This was our very important actor Siddhant, then our anchor Rohit, then another Siddharth Shukla. And this is a video I could get. A Lebanese singer, Majida Al-Rumi, fainted during the Jarash Festival performance, and she was just spotted getting unbalanced, and she ultimately fell down, and she had this event of sudden cardiac arrest. So all these events, these things are happening while people are performing on the stage in India, and many places beyond that they were performing, and they were captured on the TV. Our Kalam Sahab also had similar kind of thing. And when I came to Delhi, I was very junior doctor. General B.C. Joshi collapsed playing the golf in the golf course, and he was very meticulously checked every day. So what I mean to say that the incidence of sudden cardiac death increases markedly with many factors, like regardless of sex, but with age. Sometimes, but normally it is being seen, as Saurabh told me, in the young age. And CHD is the most common substrate underlying sudden cardiac arrest or sudden cardiac death. And post-myocardial scarring also can lead to it. And many other things leading to delayed risks. What we know as congenital long QT interval syndromes, genetically based primary arrhythmia disorders, short QT syndrome, Barguara syndrome, the most commonly talked about, idiopathic ventricular tachycardia, ventricular fibrillation, which could be catecholaminergic and polymorphic, and inherited structural disorders with arrhythmogenic potential, like hypertrophic cardiomyopathy, right ventricular dysplasia or cardiomyopathy, another subtype, and genetic predispositions. We are working hard on that direction. Could be genetic, a drug-induced, superimposed drug-induced acquired long QT, precipitated by drugs, electrolyte imbalance, and many other things. So the risk factors could be genetic, CHD risk factors, arrhythmias, nutritional, sometimes psychological factors, exertion, sorry, biomarkers. So if we summarize that either we go on this side of CHD or CHF, and could be old fibrous scar, hypertrophic fibrous scar, altered calcium channel regulations, then it all triggers to one common disorder, sudden cardiac death. Our heart is like a machine, and this machine has to work perfectly, as I say, from the womb of the mother till the last day of her life. The heart keeps beating. It doesn't go on leave. This is a perfect machine which keeps us active, alive, and going. And the heart adapts to our needs. Sometimes it breaks down, and then we have the scenario of this kind, either in the office or while playing. So sudden cardiac death is the silent killer. And it kills roughly, as per data available, 800,000 people each year. And we have to be geared up. And in countries like Singapore and USA, from where you are listening to my talk, you are already well geared up. And we are also trying to do many things to fight this menace. The life can be saved. The coronary artery disease causes 80% of the sudden cardiac death cases. In the young, it may be caused by a genetic disease, as I said. Some syndromes I have enumerated. When an athlete dies, medicine has failed. We can say that. Public awareness, therefore, is of utmost importance, and especially after COVID, how much exercise to do. That has to be learned by people, especially youngsters, the executives of companies, and so on. And we have to really advise people how to go about exercise and preventive measures, because to some extent, I would say it is preventable, and the prevention starts much early, like quitting smoking, having healthy diet, avoiding junk food. So these are the various cartoons I have made just for the people who are not medical also, because I keep telling my patients also. And therefore, prevention of sudden cardiac death requires a global approach. Though we only talk about SCD when an elite athlete dies, but in day-to-day practice, we have to be geared up. So more research is being done on the preventive side, and we are successfully approaching to various measures, and we have developed modalities to save lives, and it's all about first 10 minutes. So while I'm talking, I just say to impress people that many people have died during this talk. Some of them may be youngsters. So in the events category, when we chart it in general population, in high-risk groups, prior coronary event groups, ejection fraction, that's the heart failure with low ejection fraction, cardiac arrest survivors, arrhythmia risk markers, post-myocardial infarction, the incidence rises. So this is a chart which says that in the young age and in the advanced age, say 45 to 60, there could be a difference of categories with the risk increasing. Like we have to look for myocarditis, hypertrophic cardiomyopathy, long QT syndromes, right ventricular dysplasia, anomalous coronary artery Verguada syndrome, idiopathic ventricular fibrillation, while at the age more than 45, beyond 45, 50, 60, could be coronary atherosclerosis, known for the first time, dilated cardiomyopathies. We have a lot of people walking on the road in India with dilated cardiomyopathy, infiltrative heart diseases, and valvular heart disease. So if we see in the males and females, there's a difference of risk factors. CAD pronounced more in males, while dilated cardiomyopathy and RV dysplasias, long QT, congenital, and coronary artery spasm more in the females. So we have to be very vigilant while we are attending these cases. If we see in Indian perspective, this is one of the our hospitals data. It's not very recent, but it's about more than 5 years old. So annual incidence of sudden cardiac arrest is 0.5 per thousand population, which accounts for 50% of the cardiovascular deaths in India. And as this has to be changed now, the peak age of SCA occurrences between, I would say now, 25 to 75 years, and a survival rate of with less than 1%. There was a South Indian study similarly, which shows also about similar results. And in this study, CAD was observed in 66 and MI was in 33, like 38 and roughly 18%. So we can say, based on the statistics, that the topic which we have covered today contributes to roughly 10% of the overall cardiovascular mortality. And sudden cardiac death cases were 5 to 8 years younger. Now we say 10 years younger as compared to the population in the Western world. And therefore, we have some more modifiable risk factors apart from age and family history, male gender, genetic disorders, which are non-modifiable. We have smoking, hyperlipidemia, obesities, sedentary lifestyle, hypertension, diabetes, and renal dysfunction, which Dr. K. Agarwal always used to tell us that prevent cardiovascular deaths by attacking these all modifiable risk factors. And he was very keen to talk about beyond cardiac arrhythmias, coronary artery disease. He was very keen to demonstrate and talk about, and his mission, I can say, was to teach people how to revive a patient who had sudden cardiac arrest. And this was his mission. And CPR, and he used to talk about CPR to the extent that we should be really submerged to learn. Everybody in schools, in police used to give demonstrations. So these are all ECG markers which we can spot on routine. And there are certain nutritional factors. The young generation is now consuming a lot of alcohol, and this predisposes. And the diet should be looked for good magnesium content, and smoking and alcohol should be talked about to the people. And psychosocial, post-COVID, these factors have become important in low socioeconomic strata and depression, anxiety. There's a lot of social isolation is being seen, stress generated by change in scenario of the working atmosphere. And these are all, you know, that these are certain biomarkers in which we are talking more about this. IL-1, IL-6, CRP is very commonly tested now, BNP and anti-pro-BNP, and cystatin C is also included. So this is a wonderful place to save life if you can wheel the patient on time in the cath lab. So we can do a little bit of maneuvering and immediately implantation of pacemaker, attend the malignant arrhythmias, and this in big cities is always available, provided we move the patient on the right time. Now, I was talking about all this, so just to keep the talk short, prevention of sudden cardiac death, the young adults should focus on evaluation of causes known to be associated with sudden unexplained deaths, like primary arrhythmia, malignant arrhythmias, ventricular arrhythmias, in those less than 35 years, and with an emphasis on atherosclerotic coronary artery disease in more than 35 years of age. And this is what I was giving a tribute to Dr. KK, and this should be our mission. And this talk, if we carry this message home, this is what he used to talk: access, awareness, education. And this is just dynamically showing the circulation. And just I have put this to talk in the doctors who are not senior doctors like you, but this cartoon I liked in this video. And this shows very finely, if we observe that cardiac rhythm changes And then when this cardiac rhythm changes, the blood circulation changes, and then we have to go for CPR. And this CPR is to be learned. And this is what we have learned from Dr. KK always. He used to teach us how to correctly give CPR, and this was his mission. Many advances have been made, and many European countries have now shown that how we can save lives by assistance taken by now wearable devices up to the medical drones, which supply the defibrillator at the place in a very short span of time. And the next video I have selected, this is very close to my heart. And we must see this video just to revise how quickly this can be done. So this is Jonah. His father collapses at a social place, and then she calls 911, and then the system gets activated. And this is not very new video, but I always show this at the end of my talk. So how promptly we can do this, how smartly we can do this, and how saving the time we can take the help of drones now. And we are saying now that we should keep all these defibrillators, portable defibrillators, at the places of public interest. So the drone arrives with a defib, and now she moves and she gets connected to the central station, and they demo it, and they can monitor from the remote station, and a life is being saved. And this is how we can teach this to a common person. And this is the future of saving lives of sudden cardiac death. And I always like this video, so I have shown this video. This is very exciting to watch. You must, many of you must have watched this video. It's a famous online video for dealing this. So she gets instructions from the remote, and the life is saved. And whole of this is controlled from a remote station. So what we can say that I was told at a very short notice, I wanted to pay my tributes to this great man. And I again at the end pay my tributes to Dr. KK, and we can say that Heart Care Foundation and CMAAO, under able leadership of Saurabh and all of you senior people like Dr. Chong, Dr. Wasik Qazi, Dr. Monica, Dr. Hussain, and all our team should carry forward this mission to India and to the world, that a life can be saved. And it is the high time post-COVID that such incidences will increase, and we have to be geared up rather to the prevention of sudden cardiac death. I am very happy to say that the hospital where I am working, at all the nursing stations, at all the floors, at all the OPDs, our defibrillators, portable defibrillators are installed, and once or twice we have used them and saved lives. Thank you very much.
Thank you, Dr. Wali. It was an excellent presentation and knowledge. And so this is Dr. Wali, and who works with a very prestigious hospital in India, which I missed out the name, was Gangaram Hospital, and a very well-known hospital for cardiac treatments. Can we close the slide, sir? So I also welcome all the medical associations from CMAAO. Sir, before we can move forward, I would like to highlight what Dr. KK used to say. He had a formula of 10 for CPR. CPR is for saving lives after death. You can save the life within the 10 minutes because your brain is alive. So the formula he created for the general public, because when you see suddenly somebody who is very close to your heart, you get panic and you don't remember what you need to do. So that is where, he created a formula for everyone to remember in Hindi and English, but I will say it in English right now. To revive after sudden cardiac arrest within 10 minutes of cardiac arrest, earlier the better. For the next at least 10 minutes, compress the center of the chest by at least 2 inches continuously and effectively with the speed of 10 into 10 per minute. That will save the life of the person.
Exactly.
So, good memories. I would like to invite Dr. Chong, our chair, to start the session with the question answers. And we have a lot of questions, and I don't think 30 minutes would be enough for us to get all the answers. So we will have a follow-up session. Over to you.
Thank you, Dr. Wali, and brilliant presentation. Yeah, I think sudden cardiac death is everywhere. In Singapore, we have about 1,000 a year, and post-mortem shows that about 80% is coronary artery disease, but the other 20%, the hearts are structurally normal. So I was wondering whether is that similar to what you experience back home in your own city?
Yes, Dr. Chong, it's similar mostly, but our problem is that people do not know the pre-existing cardiac conditions. Many of our youngsters who are playing, they are having hypertrophic cardiomyopathy, and they go out and I was talking about a family in which they were very well to do, and they got whole family investigated, and all genetic markers were studied, and they know exactly what kind of cardiomyopathy this family is having. And 3 days back, the young boy who had driven in front of his father at a fast pace came with atrial fibrillation for the first time. So I did not waste time. I put, after doing the ECG, which showed atrial fibrillation, I put Holter on him and I could diagnose the condition. And now I'm just referring him for putting a ventricular device. So we do have similar patterns, sir. You have rightly pointed out.
We also see something very interesting here in Singapore called the Brugada syndrome. And we first came to our attention, I think about 20 years ago, when we had a lot of Thai foreign workers working in Singapore. And these Thai foreign workers would collapse suddenly, unexpectedly, of course, sudden death. And a lot of them were actually, in the end, found to have the Brugada syndrome. Do you have such an experience in your home country or city?
Yes, occasionally we do. We do have also. We have more cases of wide QRS complex ECGs and more of cardiomyopathies, more of post-scarring. But arrhythmias, yes, we do have Pagoda, short QT. Our young doctors also diagnose in our hospitals, and they isolate these patients, and we subject them for all detailed testing, sir.
Okay, thank you, Dr. Wali. And now, Dr. Akhtar.
Hi, good morning, Chong. Thank you so much giving me opportunity. Mashallah, Dr. Wali, it was an excellent presentation. I have few query here in your experience, sudden cardiac death. In autopsy, what are the common causes you find? Because it's non-specific, but I'm sure in your long experience, what are the common finding you have? The other small thing is, you mentioned your presentation Monday mostly happen in the morning. Can you elaborate a little bit on that to clarity? Thank you.
Monday is the adrenergic status. Monday blues, and that precipitates more rhythm disorders. That's how we have found in that South Indian study. And this was coincidental. And as you were mentioning about autopsies, in India, we don't have much autopsies. That's unfortunate part of the story. But we should have more autopsies to know exactly what are the anatomical variations, if any, in the sudden deaths. And recently, it has provoked in India that many people, many important people, young executives, people working as CEOs in corporate, they have suddenly died. And this young anchor which I had shown, he was very regular for gymming. And he was a fit person in one of the most commonly seen channel in India, Aaj Tak, and then he suddenly dies. So this all has provoked us that we should go for more for autopsies post sudden cardiac deaths, and we should isolate the causes in the different groups of populations. But a large number still would come out if we do autopsies, the low ejection fraction, heart failures, and post myocardial scarring. You would be surprised to know that in India, due to lack of resources, people with triple vessel block and triple vessel disease with previous myocardial scarring, they keep walking on the roads and they do somehow develop collaterals and they live for more than 2 decades. I have many poor patients who are less resourceful and they develop good collaterals, but they can have a sudden cardiac event if there is a myocardial scarring present. So this all would be very, very importantly dealt with post-autopsies. And we should rather, I would say that our organization should send a message to our authorities that we should make the autopsies compulsory in cases who die unexpectedly due to sudden cardiac deaths.
Dr. Jamka, you have a question?
Yeah, nice lecture, Dr. Wali. What are the incidences of sudden cardiac arrest in maybe ventricular tachycardia and other arrhythmias?
Many times these arrhythmias are missed, and many times people don't get immediate attention and reach on time to the hospital. And by the time they reach hospital, they are declared dead. But in good places, in where there are alert physicians, they do offer CPR and save many lives. So, as I said, 1 in 1,000 roughly would be the statistics now post-COVID, which is slightly higher than what we used to have. That's all. I have information with me, but I always encourage people to be cautious. And one modalities which we have probably not promoted much during these days of coronary angiography, that Holter monitoring. I also talk more about Holter monitoring to my colleagues, to the patients, explain them, and to get it repeated on time when it is due next time. So we can isolate many cases of long pauses, abnormal arrhythmias, and ventricular arrhythmias. And we do get such information after doing careful Holter examinations.
And after COVID, do you think there is increased incidence of cardiac arrest?
Certainly, yes.
Maybe
Certainly, yes, sir.
Thrombotic phenomena.
Yes, because we are seeing prothrombotic, post-thrombotic both. And we, in fact, first case when COVID started, I remember, sir, unbelievably, I would say that the young lady came with a gangrene and lot of abnormal markers and heart was normal. And probably that was the case who had thrombotic episode after COVID. And simply we are managing these cases. I have a lot of cases whom I have treated during COVID, so we monitor them regularly by seeing the CRP. This is the common test I am advising, and I find many abnormalities and then I subject them to detailed testing.
Roughly after COVID, how many patients of sudden cardiac arrest you have seen they had suffered from COVID?
Sir, we have documented many youngsters and performers. You must have seen in the news also. The incidence definitely, as you asked in the first part of question, has gone up. Same, we have seen diabetes has gone up. CAD diagnosis is more. But the underlying causes which these youngsters have, they have cardiomyopathy and there is a change in this lifestyle. A lot of people are opting for gym. So we have started telling them that don't do ungraded, unsupervised exercise because of this reason. And they are now listening to us, and they are not running, and they are not unmonitored, not doing unmonitored exercises. So this is how we are trying to educate our population.
Thank you, Dr. Wali.
Dr. Wali, what are your thoughts on this sudden death that we see in athletes, as in a recent incident in America? I think Monica would know this. NFL footballer was hit in the chest and he just collapsed. Sort of blunt trauma to the myocardium. What are your thoughts on that?
Thank you. Cardiac concussion.
Yeah.
Yes, this footballer, I would say, was not 100% true, but this is a very important phenomenon, as you have rightly pointed out. Without this talk would be incomplete. This cardiac concussion is a sudden hit to the chest and sufficient enough to provoke the cardiac arrhythmia. The hit should be such that it should traverse through the chest wall, traverse through the outside of the heart and hit the myocardium and provoking a traumatic arrhythmia. I can say, just to explain myself, it's just like a trauma to the heart. And it has also been seen in past in many cases. And this footballer's incidents made it more prominent. So we strained our hearts and we revised how it happens, and various mechanisms were understood. So basically, yes, it is one of the very, very important cause of sudden cardiac death. And my professor, I would remember that this was taught. He used to teach us from a cardiac textbook, Paul Wood's textbook of cardiology. And Professor Ram Singh, I recall when I was a third-year medical student. And he used to mention this, that what is athlete's heart? Athlete's heart, now we know in detail what's athlete's heart. And at the top of it, concoctiocardia or myocardial concoction is a very important thing to remember, and to understand the physiology in detail and how it happens, how it affects the calcium channels, and how it affects the cardiac metabolism suddenly at this fraction of a second. And this is very important to remember and to talk about. Sorry, I missed this part, and I will definitely incorporate this in my next presentation. Thank you very much, sir. I'm indeed grateful.
Yes, commotio cordis, that's right.
Commotio cordis,
and I remember
yes.
reading that the hit, it occurs at a certain part of the cardiac cycle, actually I think just before the T wave or the ST area or something like that.
Sir.
Yeah.
Yes, sir.
And it's very unfortunate that it hits exactly at that
part of the cardiac cycle and ECG. And this is a superimposition of doom.
Sir, just one question. In this case, when the ball or something hits your heart, I know in electric shock, the CPR works almost 100%. Does CPR works on this also like 100%, because your heart was perfectly fine? You don't have any problem with your body. Just because of one episode, your heart stopped functioning. Does the CPR works on this 100% as well?
It should work. It should work, provided the nature of the impact and the intensity of the impact is tolerable. It should work.
Dr. Wali, I also understand that sometimes when these events happen on the field, because they are in such a high adrenergic state, these players, that when a collapse occurs, actually it's quite hard to resuscitate them. Is that true?
Yes, because the commotion is such and the panic is great. So like we had many events in performers. One young man was performing at Ramlila, one other young man was singing, one other young man was performing the role of goddess Savitri, and they just collapsed, and this earlier part of their death was thought to be part of their presentation at the stage. And this was very misleading. And this has happened in more than 3 cases, that people thought this part, when the person collapses, is part of his performance, and they did not pay attention. Unlike the singer which I had shown, she collapses and somebody holds her and takes her. In other case, when our singer was singing, the stadium was jam-packed and people thought he's suffocating, he's having air hunger and he is not getting enough oxygen. So people tried to move him in a manner as if he was not a patient, he was made to walk. So all this we are learning day by day, sir. And this your questions are very eye-opener for all of us who are involved in the assessment and treatment of these sudden cardiac deaths, sir. Thank you.
Yes.
And that's how it delays.
Thank you, Dr. Wali. And I remember reading some data from the Veterans Administration that after COVID, you were talking about COVID-related, arrhythmias and so on. I remember reading that arrhythmias were increased by 70 to 80% post-COVID. PE, like heart attacks, 63% more. Pulmonary embolism, 300% more. DVT, 200% more. Indeed, COVID is actually a very, very powerful thrombogenic and cardiogenic event.
Yes, sir. I fully agree, because it kills the person with various mechanisms, which we are gradually understanding.
Yep.
And I said the first case which came to my clinic was a lady, and that she had a gangrene-like presentation. At that time, COVID had just started. I don't know when we have declared COVID has started in India. We were probably a few months late.
Thank you. Anybody else has any questions for Professor Wali?
I have a question.
Please go ahead.
Thank you, Dr. Wali. That was a fantastic presentation. And I think that even not just for medical professionals receiving your talk, but even as people in our community, it has implications that are far-reaching than just being in medicine. I think it's much more social implications. And I think this builds the football team example and the drone example you gave are beautiful, highlighting the role of bystanders, the role of available of AED recognition and training of people to understand when these events are happening. Public awareness, I think our work is never done. I think whenever we see a patient who is at risk, and just even spending a few seconds to assess their knowledge and to address knowledge gaps associated with quick resuscitation, I think is phenomenal. You had a great presentation that highlighted all of those concepts. And thank you very, very much for knowing Dr. K.K. Agarwal and sharing his vision.
Thank you. Monica, we have a QRT in police. I have been seeing the vans written quick reaction team by police. We should have a QRTs for quick resuscitation teams in medicine. And with that, I thank you very much for appreciation. It was just at a short notice that I could gather all this. In fact, as you rightly said, we have to learn the time, value of time, and differentiate between a heart attack and SCDs, and which people hardly differentiate. And they think in India, we have a peculiar thing that when somebody dies, we think it's Almighty's decision, forgetting that we could have done something more positive. And that's where I have worked in Mayo Clinic, I have worked in Michigan University and I have seen how alert their paramedics are. And I would quote, when you have provoked me to quote, I was in London in one of the hotels where I took former Prime Minister Mr. V.P. Singh for treatment, and I saw in the morning an ambulance in the hotel. Inside the hotel, normally cars are not allowed. So I asked the paramedic who was running with a stretcher upstairs, so since I could have an access, so I just walked with him, and he says, one of your musicians, Ravi Shankar, is having hypertension, 170 100 blood pressure, and we are rushing him to the hospital. And this taught me a big lesson, how important to them was high blood pressure and how ignorant we are seeing high blood pressure. Our people are walking in OPD with 240, 120 blood pressure and saying, I'm fine. This is the difference. This is where we have to bridge the gap. People leaving medicines on the pretext that medicines have finished. People ignoring their blood pressure, which is one of the very, very important cause of operating underlying. And this is what you talked about. Public awareness is utmost important in educating people who are negligent about their health, their children eating junk food in front of their eyes. They are seeing, now we have a trend in India, you may be aware that we are sleeping and our children are ordering at 2 a.m. or 3 a.m. in the night, and in the morning we see the empty boxes of pizza and some other junk food in the morning, and we just come to know that the children have consumed the junk food in the night. So this trend we have to really change. And this is probably, we have to learn how wiser people are becoming in USA and other countries, and we are learning their habits, and probably for the worst. Thank you so very much, Dr. Monica.
Many of the food is the junk food now.
Yes.
At least in India, I see my nephew's menu, which has been designed by the school, a reputed school in India. It has pizzas, it has pastas, it has everything. And I said, when you learn from the school, then nobody can stop you eating the junk food, because you get into a habit of doing that.
In fact, we should, Dr. Agarwal, you are right. We should teach the students how a scooter was invented, why scooter was invented. Same way the junk food is invented because of various social reasons. Now that the fresh food is available in India, our mothers are cooking, and so children should be taught the importance. Now I would say in the last that our Prime Minister has probably very rightly entered into talking about millets, the fibrous foods and the food of tomorrow. And I was very pleased to know yesterday that the Parliament canteen in India has started serving preparations of millets, the poor man's food. A long back when Mr. George Fernandes was alive, I used to treat him, and he would have ragi ka halwa in the morning and ragi roti. And I was not aware at that time. I was also very young, and I was learning things, how the things happen in large cities, big cities like in Delhi. And since he had a rural background, he was consuming ragi. And then I also started promoting ragi for iron. But this was, all poor man's food are very healthy. That's the message at the end of this talk, I would say. So we should go back to them, and they're cheaper and they're healthier, they're fiber rich, and they help in reducing cholesterol, keeping our lipid profile healthy, and probably they keep our gut healthy. We talk about gut in many diseases now, microbiota and everything. So all this futuring together, I thank at the end that our Prime Minister has brought this. There's the International Day of Millets declared, and Parliament canteen has started serving millet food articles, food items, and so on. And probably we would save a lot of food grain, and we would resort to the crops which we have in plenty in India, and they get wasted because they are not being optimally utilized. So good.
Okay, sir, and I have a few questions which I have come on the social media before we can end this session. And you rightly said, sir, millet as a brand has suddenly come up because there's a word millet, but nobody knows that millet was an old man food, poor man food. And since it is a fashionable name, so now people are ordering it and trying to see what it is. Having said that, I have a few questions from the social media. One question is, are there at least any early signs to be watched and to prevent the cardiac arrest? Also, is there any thing to figure out whether your body has any blockage? Are there any preventive body tests to be done?
I always tell people to watch for unexplained rise in heartbeat, that is unexplained tachycardia, unexplained breathlessness, unexplained headache pointing towards hypertension. It's something which you are not very much used to have. If you have these symptoms, don't ignore them. Go to a doctor, go to a good doctor, have at least an ECG, if needed, get a Holter examination, get your blood pressure checked. These are probably early warnings, which we ignore, most of us. And I would say that the doctors, I would say here I have become a little emotional now. I went to one Professor Robert Kyle, who was a specialist in myeloma and who was taking history of one of my patients. And like a third year student, he sat up with the questionnaire of what we write in day to day in our case sheet. And I'm sure this happens all over with the good doctors, that they do not miss important parts of the history taking. And if we have a careful history taking and we explore the cardiorespiratory symptoms, probably Dr. Agrawal, you have rightly pointed out, we may not miss these early signs, and some thumping, or if you ask the patient tells, yes, I have thumping in the chest, I have some restlessness, or sometimes the patients get up at 2 o'clock in the night. And this many patients of mine tell me, yes, I get up at 2 o'clock in the night, and that points out to either early heart failure or paroxysmal nocturnal dyspnea, or a very early sign of incipient heart failure, left ventricular failure, and unexplained bradycardia or unexplained tachycardia in ECG. This could be very, very cost effective and early signs which we should not miss. If a patient is having bradycardia and patient is not on beta blockers, I always explore the history further. And I do find certain cases of hypothyroidism, or at least 1 or 2 cases I diagnosed with ECG that patient is having cardiomyopathy. So this is what you are right, that inexpensive and thoughtfully asked questions from a patient, which are pointers, which probably this clinical medicine is fading day by day, and we are resorting to more investigations, and investigations can miss a finding which patient's history can always tell us. So a well-taken history and well thought, because there are constraints of time in big OPDs and crowded OPDs, we always miss some part of the history of the patient. So a carefully taken history and the questionnaire which we are supposed to ask from every patient, we should probably get back to this old practice. And then, as you said, we can have some more cases which we can diagnose and further investigate. And in a country like India, where we have all spectrum of financial status of the patients, we can probably contribute by taking a good history, and we can diagnose many cases before they create sudden cardiac death.
So 2 more questions. First is, there was a video which got viral that every person should hold four or five tablets in their pocket, and if they feel there is any cardiac problem, they feel there's uneasiness, they should immediately consume that tablets. So can you please highlight if that's
yes,
true?
there are many videos, they get viral, like you cough forcefully, you thump your chest, and you eat this all clopidogrel aspirin. I would say, yes, talk to your doctor before keeping them in your pocket. And if you really need them, do have them. But before that, get a proper medical checkup. You see, this is an important thing, could be sometimes life-saving also, till you reach to the hospital. But I don't think if you have any contraindications to these pills like aspirin, clopidogrel, and taken in right dose, they could be harmful, unless you have a bleeding ulcer or some bleeding diathesis or something contraindicated. Yes. Most importantly, I keep giving more importance to the blood pressure. You see, people are ignoring blood pressure a lot these days, especially in India, where the weather changes. By the time our body gets used to cold, summer comes. And by the time we get used to summers, winter comes. And many patients need recalibration of doses of hypertension, and many people end up in the hospital with a stroke. And as we are talking with reference to COVID, body becomes more vulnerable. In fact, I suffered COVID like Dr. KK, and I still have changes in my lungs. I still have tachycardia when I walk fast. I have ECG changes, ST segment depression, because I have one small block. So sometimes we can diagnose all these things by careful, simple investigations and carefully taken history, and all these pills which you're talking would be of benefit. But unsupervised use of anything is not, I would not recommend.
Thank you, sir. So the last question is, earlier we used to see the trend changing from the heart attack from, early 50s to 30s. And now suddenly we have seen over the last few years that people below 20 are losing their life. In fact, yesterday and last week, there was a girl who was a doctor from Indore, lost her life at the age of 16 with a cardiac arrest. So is there anything which below 20 is like, you're still young, you're still not even completed your teen. What's going on in this world, and what is the take-home message with this?
Thank you for asking this question. My profound sympathy to the family of that girl. And in India, we are now not talking much about valvular heart disease, rheumatic heart disease, rheumatic carditis, rheumatic myocarditis. In India, we still have them. And as I mentioned, there could be certain syndromes associated with certain cardiac death. She could have one, and she might have had some valvular heart disease. So I've seen children growing with ACTs, valvular heart disease, and many ladies have conceived and delivered with mitral valve disease. And they were not, nobody kept a stethoscope on their chest. And second delivery or third delivery, they were diagnosed. So we in India had a lot of rheumatic heart disease and components associated with congenital diseases of the heart, especially conduction system. She was too young to have a complicated cardiomyopathy. I don't know, but she could be one of the categories. So we should not forget to examine everybody, at least listen any murmur if one has, and diagnose the condition underlying. And I'm sure we would learn more lessons from this sudden death of a medical person.
Thank you, Dr. Wali. Anyone has a question? Dr. Kazi, anyone has a question over here? Any associations?
Yes, thank you, Saurabh. And it was excellent presentation by Dr. Wali. And there was a video on self-CPR. My question to Dr. Wali, what are his thoughts on it? Self-CPR. There was a video on social media.
Yes, I have briefly mentioned about if you have this kind of symptom like you're going away, you're fainting, then if you can manage to cough and put a thumb on the chest, would be, if that much is energy is there in the body, yes. And I would learn more about it, as you pointed out, and include this video also in my presentation. So yes, there could be something like we have to stimulate the vagus nerve somehow.
Okay, thank you, Dr. Wali. You have very rightly mentioned the the efforts Dr. K.K. Agarwal has put on importance of CPR. And I think we, as medical associations, we should educate more aggressively on public awareness of CPR. And I think we should educate for putting this subject of CPR in the educational institutions, in the curriculum of the educational institutions,
Exactly.
How to do proper CPR. So I think we should need to work on that. And it's really important that everybody should know how to do a proper CPR and when to do it. And the use of technology coming up, like you have shown an excellent video of drone delivery. of the information and the equipment to deal the sudden cardiac arrest or sudden death, we can have a bright future in the coming years and months. I think we need to work on that also as medical associations, as national medical associations, and from the platform of CMAAO, we can always advocate for, putting in the curriculum of the education system also, so that from the younger age, the students, the college students and school students should know, and repeatedly when they will have, that knowledge being hammered into them, they'll have a much positive role in this society.
Thank you, sir. Thank you for your kind words and wisdom words.
In fact, sir, I think what Dr. KK also did, I want to highlight that he trained the police officers, the
Yes.
traffic police,
Courts.
yes, all. So these are the people who can reach your house very fast. And we were in a words of training the delivery boys, because, in this stage where ambulance reaches more than 30 minutes or half an hour, 1 hour, the food gets delivered in 10 minutes. So we were, our focus was to train all those people who can be around your bystanders, can give you training, can save your life by CPR, train them. And CPR is something which you don't need to be a doctor. Any bystander can do a CPR and handing over to the doctor. So that initial 10 minutes are very important. Over to you, sir.
Saurabh, I have to apologize for not mentioning anything about obesity in young. All these delivery boys are making our children obese. Just I remember it. So proper food. Yes, I talked about junk food. We talked about junk food. So obesity is another risk factors, and history of snoring, as you were asking me, could be the early sign of one of the early signs of having cardiac arrhythmias. And most of our youngsters do have snoring. So while taking history, we should also take history of snoring and any abnormal beating that's ectopic. So patient can tell sometimes if we ask those. So early signs, I would add two things, history of snoring and history of having abnormal beating or thump in the chest, unaware, which the patient is unaware of. Thank you.
Thank you so much.
Thank you. I learned many things through this talk. So I thank all the people who have tried to ask questions so that I scratch my mind and learn something and get provoked for learning further. Thank you very much. I'm still a student, so if I have made any mistakes in my presentation, please ignore them. Thank you very much.
Thank you, Professor Wali. And if there are no more questions for our speaker, I'd like to thank our speaker for a wonderful presentation and his humility and his humor. And all the things that always make us remember such a presentation so well. Without much further ado, thank you everyone, and happy Lunar New Year. Today is the first day of the actual spring itself at 10:43 in Singapore. So yeah, we have just welcomed the actual New Year itself according to the cycle of the moon. So thank you everyone, and we'd love to see you back here again soon for another wonderful presentation from another wonderful speaker. Thank you so much.
Thank you everyone. See you again.